everyone, I'm Natalie Kunsman, MD, and today we are talking about apnea. So let's define what apnea is first. And apnea is basically a cessation or a period of time where there is no breathing. There are two major types of apnea, and one of them is central apnea, and one of them is obstructive sleep apnea. So we will briefly talk about central apnea, which typically will occur in two particular instances. One is in prematurity, and that is where the hypothalamus is just simply underdeveloped and having difficulty perceiving the oxygenation and when to stimulate the respiratory drive. And of course, there may be several other reasons, but one of the other big reasons, which is seen in the altitude area where I am currently practicing, is in the higher altitude or environmentally hypoxic areas. And again, that also will confuse the hypothalamus and some of the reticular activating system, which is partially responsible for our drive to breathe. So, of course, there are ways to evaluate the central apnea, but the primary bulk of today's discussion will be obstructive sleep apnea. So, obstructive sleep apnea is what the name implies, and there is some obstruction to the airway or the respiratory tree, rendering it difficult for us to oxygenate, and therefore there may be periods of time where there is no breathing. Now, typically the periods of time will be seconds, let's say, but we will get into how to evaluate this shortly. So, obstructive sleep apnea is actually on the rise, in particular in the United States. And there are a couple factors, and some of them may be obvious and others may not be so obvious. Interestingly, or maybe something very obvious to the average patient, is the rise in obesity. So if we are obese and we lie flat at nighttime and our tissues are rendered a lot more relaxed, the weight of the chest and the weight of the tissues will obstruct the airway. And over periods of time where we may be hypoxic for a few seconds at a time, a big respiratory drive to open that airway will happen, but this may go on for multiple times per minute, multiple times per hour. And again, that obesity is a big portion of what is causing the obstruction. Now, something that may not be quite as obvious in the rise in obstructive sleep apnea is actually the change in our American diet, the change in which we raise our infants, and the change in some of the anthropometric information that we have now versus many, many years ago when obstructive sleep apnea just simply didn't exist. So one very obvious piece of information that we have studied is breastfed babies have much less obstructive sleep apnea over their pediatric years and into their adult years. And one of the proposed mechanisms, which is actually making very logical sense, is the sucking mechanism for breastfeeding requires a lot of musculature of the tongue, requires a lot of coordination, and basically a lot of action that will actually make those tissues very strong. The tongue thrusting in the suckling process will actually mold the palate and the jaw to its appropriate proportions so that over time, not only will the teeth necessarily be straighter, but when it is time for the chewing process, the child is much more able to swallow and keep structures intact. And now if we have bottle-fed babies who have to exert nearly no effort to ingest the milk, their tongues are not as strong. The tongues may be, I'll just use the word lazy for lack of a better word. There may be some tongue thrusting forward, let alone if we convert that baby early over to soft foods that require minimal chewing. And again, the chewing is necessary to develop our jaw structures. Let alone if in the toddlerhood, he or she is eating mac and cheese and soft foods and not really getting into the aggressive myofunction of the swallowing mechanism from the dentition in the front to the tongue, to the coordination practice, to the coordination through the epiglottis and the esophagus. This may render the tissues less strong, less functional, and will actually change the anatomy of that developing child. And there may be such things as high arches affecting some of the sinuses. And again, as the child sleeps, especially if there is swollen tonsils, swollen adenoids, on top of all that, that child will wind up having an obstructive night of sleep and apnea. So what will an apnea patient look like when they are presenting to the office? Well, for some of the children, we may notice bedwetting. We may notice poor growth because growth hormone is secreted at night, and if that is impaired with the apnea process, they don't grow as well, so they can be failure to thrive. We may notice psychiatric issues, and a big one, which we have not always attributed to apnea, is attention deficit disorder. Of course, there may be dental issues, there may be swallowing issues, there may be chronic sinusitis, and with the chronic sinusitis and antibiotic use, that may trickle down to have a lot more inflammatory conditions. Let alone if that child winds up being obese in addition to some of these issues. We have a whole cascade of events that if we can fix them in infancy and toddlerhood, we may be able to prevent them in adulthood. Now, the adult who presents with sleep apnea very easily can come in with impaired concentration, excessive daytime sleepiness, which is obvious, lower cognitive scores on exams, more accidents while driving cars, and the trickle-down effect down the road in addition to this winds up being some comorbid conditions, believe it or not, including some diabetes and heart disease. And for some of the hypothalamic pituitary-based hormone release, we may actually notice lower testosterones and lower hormone performance. So that is how somebody will present. This is what has led to much more apnea in America. So how do we go about treating this in the first place? Well, obviously we need to identify the issue. For the premature infants and the hypothalamic immaturity, we simply need monitors, and we will need airway pressures and alarms and things like that. And that's a small subset. For the obstructive pediatric patient, first and foremost, the oral mechanism can be many times fixed and modified with appliances. And these are served best in the hands of some special dentistry that does a lot of this corrective measurement so that we can have corrective appliances, and those appliances will need to modify over time as the jaw structure is improving. And as my dental friends will tell me, a lot of patients don't come to them until there is an orthodontic problem. But if you fix the palate and the jaw and the tongue myofunctioning and the sinus construction, many times the teeth will line up and be straight. Therefore, you would not need orthodontics. So again, we have some appliances. There are some very crude mechanisms where you can actually get breathe right strips and things to sort of open the airways. But then when those things fail, and we may have some surgical techniques such as a uvulopalataloplasty from the ear, nose, and throat physicians, or for those children that have simply obstructive tonsils and adenoids, they may need to come out. So there are ways to use appliances and remove some of the tissue to open the airway. If that does not work, then we are talking about the necessity for Cpap machinery, which is continuous positive airway pressure, and that requires a sleep study to evaluate which pressures are needed to keep that airway open to maintain the oxygenation through the night so that there are less apnea events. That requires a face mask, that requires a contraption, sometimes humidification, and sometimes oxygen in addition to the positive airway pressure is needed. Then there is a BiPAP contraction, which will actually have two-way pressures to help maintain the oxygenation. And one of the newer techniques, which is a little bit more physiologic and can help you continue with the evaluation process, is the automatic airway pressure that will adjust its pressures on demand for what is needed in that breathing event. So that will require a pulmonologist, sometimes your family physician. We may require an ear, nose, and throat physician, and we cannot forget our aggressive dentistry family that can help with some of these appliances. Again, the preventive tactics may be as simple as breastfeeding, a normal diet that requires a lot of normal chewing, less pacification in our very young clientele, and the evaluation and identification early on is the key. Again, we probably have just scratched the surface with this ever-pervasive problem that contributes to so many other health conditions down the road. So I will enjoy any questions you may have for me. Subscribe to my channel below, and until we meet again, be well.